My name is Jasmine Kamboj, and I'm a medical oncologist and hematologist at Allina Health Cancer Institute, also called as AHCI, in the Twin Cities area of Minnesota. At Allina Health, I have been chairing the Cancer Committee program and the Precision Oncology Committee program over the last several years. And today, I'm super excited to speak with Dr. Brian Alexander, CEO of Foundation Medicine and radiation oncologist specializing in neuro-oncology.
Thanks, Jasmine. Really looking forward to the conversation, and thanks for inviting me.
Perfect. So Brian, just to begin with, can you lay some context on Foundation Medicine, its vision, and your role within the organization?
Sure, absolutely. I'm the CEO of Foundation Medicine. I came to Foundation Medicine in end of 2018. As you said, I'm a radiation oncologist focused on neuro-oncology at Dana-Farber and Brigham in Boston. And Foundation Medicine was started in around 2010 with the mission to transform cancer care based on this, the increasing understanding that cancer was really a disease of the genome. And there's a lot of research efforts, whether it was the Human Genome Project to characterize normal, Cancer Genome Atlas to understand the alterations in cancer, and really the founders of Foundation Medicine thought, this technology will be essential for cancer care in the future, and wanted to develop the technology to be able to make it a routine part of cancer care. So we still have the same mission to transform cancer care, and the way that we do that is by making this molecular profiling and a deep understanding of cancer available to really guide decisions in both clinical practice and clinical research.
Great, wonderful, thanks.
So in that context, as we think about cancer care transitioning more to a disease that's identified by histopathologic criteria, but also of the alterations in the genes. How's Allina Health thinking about precision oncology, and where does that fit into the individual patient cancer journey?
Yeah, since we're Minnesota based, we like to think about every cancer as a snowflake. So every cancer is different, and that's where precision oncology comes into picture. Molecular profiling by next generation sequencing has been a pivotal part of the AHCI journey. We started around 2 years ago when we started the task force for precision oncology. Then we evolved into our stewardship committee with the growing FDA approvals and new therapeutics coming into the pipeline. And now we also have a strong, robust in-house reflex testing program by our wonderful pathology team. And thanks to the Foundation team, after 1 year of collaboration with Foundation, now we have formally partnered with the Foundation as our commercial partner. So I'm very proud of that success and journey. We're also very intentional about all these results. And as you know, the results can be very complicated sometimes. And so we have a hybrid tumor board platform where our in-house pathology colleagues and the consultant commercial vendor team comes together and discusses all these complicated results. And we talk about actionable alterations, the biomarker results, any resistance mechanisms, any FDA-approved treatments, off-label treatments, and clinical trials that might be available. So I think molecular profiling in general has been paradigm shifting for our patient care. We have obviously changed from histology-based to a biomarker-based management, profile. And Keytruda approval in 2017 based on MSI and deficient MMR was the landmark milestone in this regard. Yeah. So I'm glad we're keeping up at Allina Health on this level. Yeah.
Yeah, absolutely. I think when we think about all the Foundation Medicine kind of offerings, I like the way that you said, the partnership. We really value partnership with organizations because, you have docs that have committed their lives to cancer care, whether it's the pathologist in the lab or the doc seeing patients in the clinic. And we really value that relationship with other, providers that are providing that. So, where we start thinking about our product, so to speak, we really want to start with high quality tests. So like what you said was really important. Like this is complicated information. It's not only complicated information once you have all the variants and there's clinical decision support you need, but it's complicated information coming out of the lab, going into a pipeline, coming out of the pipeline, going into that report. And, it's not just like a easy to interpret test. And you talk about MSI, but there's tumor mutational burden, some of the fusions that are called. And, our two main kind of products are Foundation One CDX and Foundation One Liquid CDX, which are basically a molecular profiling in tissue, tumor tissue taken out of the patient, or blood. Similar gene panel, 324 genes, similar kind of complex biomarker readouts. We also have, Foundation One Heme, which is unfortunately called Heme, but it's for hematologic cancers and sarcomas and anything else, but it combines RNA and DNA. And then we're really excited about the next year we're launching Foundation One Tracker, which basically takes all of the information from if you've had a Foundation One CDX test and all of that molecular fingerprinting that you've done, and through a collaboration with a company called Natera, we say, let's look for that fingerprint in the blood so that we can track whether the DNA of the tumor is present in the blood, whether it goes up or down, what that means for changing therapies or monitoring for disease after surgery or radiation. So that's kind of our suite of offerings. When we say like Foundation One CDX or Foundation One Liquid CDX, that CDX is a companion diagnostic. Okay. And what that means really is that the actual clinical data that was submitted to the FDA to get approval for the drug had either our test as the test that was used, or we've bridged to show that like our test says the same thing as the test that was used in the clinic. So what that means is there is a direct link between the evidence that's used to show the drug works and our biomarker showing that we can identify patients for that drug. I think the other thing that a companion diagnostic means is that you can go on the FDA website and look up Foundation One Liquid CDX or Foundation One CDX, get 100 pages of like quality data, like how well we call different variants, how deep we sequence, what our limit of detection is, a limit of blank, things that took me a while to get to know when I came to Foundation Medicine. But we have an active relationship with the FDA. They audit us. We kind of, work with them. And so at the end of the day, we just want people to know that they're starting the diagnostic and decision journey with the highest quality information that you can have. So that's really important to us.
Yeah, audits are some things we're all desperate for, isn't it?
Yeah, exactly, exactly. But at the end of the day, if like the doc, like seeing the patient can feel like I don't have to question the result of this test, like that's how it all starts. Well, I mentioned that cancer is a disease of the genome, and I talk about genomic, but people hear genomic, genetic. Is there a lot of confusion in clinic, and how do you talk to your patients about that?
Oh yeah, that's a universal patient question, and to be honest, I think it's a confusion in healthcare as well. So to simplify, the word genetics is basically a study of the genes, which is a unit of inheritance, as we know. And genomics is all of the genes of a person in their entirety and its connection with the environment a person is exposed to. And the genome can further be divided into two categories. One is the germline genome, which is the inherited mutations, et cetera. And one is the somatic genome, which is the changes in the DNA that lead to cancer sporadically or randomly. Both are extremely important. And as we know, 90 to 95% of the cancer is actually caused by sporadic or random mutations, not by genetic mutations. So when we're doing biomarker testing by NGS testing, et cetera, it's the somatic genome, which is basically the DNA of the tumor of the person that is being tested by NGS testing. Mm-hmm. So I hope that's better and clear.
Yeah, no, yeah, absolutely. That's very concise.
Yeah. So tell me, Brian, the reports that Foundation One generates, they're, you mentioned a little bit how complex they can be. So tell me, why are they complex, and like how can a person try to make some sense out of it, essentially?
Yeah, I think you touched on it before with you talking about all of the different kind of things that you think about when in instituting a precision medicine program, whether you talk about tumor boards and you talk about different kinds of therapies. I mean, I think ultimately the report is complex because the information is complex, and
right.
And that doesn't mean we shouldn't try to simplify and shouldn't try to like get into a place where it's more easy to understand for people who are busy. Mm-hmm. But the explosion of information that's happening, there's new biomarkers, what those biomarkers mean, there's new therapies, all of these things. You could our report is almost like a review article on all of the variants and what it means, which can be really great if you have time to read a review article before you see the patient. But what we want to kind of keep evolving is kind of still have that deep content, but make it easier to interact with. So, things that we've done are have a clinical actionability summary. Like here's what it means. Like now, if you want to double click and go into any of the variants and learn more about it, like go there. The other thing is like the digital experience. Like how do we leverage the digital experience to help kind of, not only have all that information, but have that information turn into like usable knowledge at the point of care. This is going to be a work in progress. And this is why it's great working with groups like you, because you're actively making decisions with the information. And at the end of the day, Foundation Medicine, the people who work here for the mission, isn't to like throw a test result over the fence and like, hope it works. Right. We really want that information pulled through to a decision. Like the patient and the doctor know they're making the right decision and know that they have access to the right therapies and clinical trials and all those kinds of things. Because information is just information if it's not impacting patient care. So, and that's why it's complex, but it's our responsibility and with partners like you to reduce that complexity so that that information turns into the best decision for the patient.
Totally. Yeah.
So we talked a lot about kind of technology and we've talked a lot about all the complexity of information, and it just feels like there's more and more going on. But at the same time, how do we know that sometimes like technological advances or information advances can increase disparities of care. And so how do you think about that as you're putting together a precision oncology program with like these like high level technology? We need tumor boards, we need all this expertise. Right. At a time when that those advances can just kind of exacerbate kind of disparities in the system already.
Absolutely, and that's a topic that's, I think, very close to my heart personally, because I've worked in rural America for so many years, and I think the biggest thing that we all need to keep in mind as we are devising these plans or making cancer programs, etc., that all of the regional and rural or community clinics, outreach clinics, should be somehow related to the bigger motherships through the hub and spoke model. So any of these tests should not be just available at the comprehensive cancer centers or the academic comprehensive cancer centers, but also should be available in the smaller outreach clinics as well. And I think Allina Health actually does a great job with that. Because we have the central bigger hospitals and then the multiple regional clinics, and the turnaround time at the regional clinics and the bigger centers is exactly the same. Actually, sometimes it's faster in the regional clinics just because we kind of defer a lot of complexity that happens at the bigger hospitals. So I think we at Allina Health are doing a great job in terms of reducing disparities, at least for precision oncology. The other thing that, I think we absolutely need to be mindful of is connectivity of, tumor boards and access to clinical trials. And again, I think telemedicine or virtual connections come really handy for those things. I do want to kind of throw it out there that the United States administration has taken big strides in this regard. President Biden issued an executive order in January of 2021 to reduce racial disparities. And National Institutes of Health, the NIH, has absolutely grabbed onto that executive order and established an institution called Unite, which is basically working towards equity and reducing racial disparities. And the National Cancer Institute, which is the cancer part of the NIH, is totally committed to this cause. And the current NCI director, Dr. Monica Bertagnolli, who is the former ASCO president too, I think she's super passionate about equity to oncology patients in rural America and underserved and racial minorities. So I think there's a lot of work that goes on in the background, which needs to be complemented at the state and local levels, and we need to do a good job at that. And I think we are. We need to be very mindful of the fact that if the underrepresented people or the minorities are not accrued on these clinical trials for precision oncology, the outcomes from these trials may not be applicable to those populations. And if they're not applicable to those populations, then of course they bear worse outcomes, which then adds to disparities. So ultimately, if we're trying to reduce racial disparities, it's not just helping those ethnic populations, it's helping the entire genome of the population. So, And Brian, on that note, I'd also like to ask you, I know Foundation One is involved in reducing disparities as well. So tell us about some of the projects at Foundation Medicine that help reduce disparities.
Yeah, this is really core to us as well. I mean, I think that, the real, one of the things that attracted me to Foundation Medicine was the ability for anyone anywhere to send blood or tumor, and we could give back a report anywhere, and you could get the best quality information, genomic information about the cancer, no matter where you were. You didn't have to be, I see patients at Dana-Farber, and like there's the third opinion, and they've gone around and like they get access to really high quality pathology and informatics. But I think Foundation Medicine can democratize that information for everybody. And so that's the opportunity. And so, it kind of goes along with, we don't get to realize that opportunity if people don't have access for whatever reason. So I would start off with just like kind of the blocking and tackling, so to speak, of that, which is like our coverage and access program, getting better coverage within different payers, our patient assistance program. 87% of patients don't pay any out-of-pocket costs. And certainly patients that are anywhere near the poverty level or those kind of things don't pay any out-of-patient costs in our experience. And we work really hard, and our teams work really hard to make sure that's the case. We do a lot of education and awareness around CGP. So there's like whether patient could get access to it, whether the people that they're seeing in clinic know about CGP, and there's like getting the results back and be able to apply those results. So and then it's partnering with like groups like you. I mean, all the stuff that you're working on to decrease disparities, like by partnering with you, we get to help decrease disparities as well. And so those are all the kind of I guess the non-research ways that we do that. And then we partner with researchers to kind of look at our database, and is it representative? And if it's not representative, how could we get there? What does genomic ancestry look like compared to disparities? And so we look for healthcare researchers that like care about disparities in research, and we've published abstracts at ASCO, and we're looking for more of those kind of collaborations. So between the research and the practice, we're really committed to reducing disparities. I mean, the other thing is like, I think making sure that our information is available at point of care. So whether that's people want to get our report back in a fax, or whether it's like in deep integrations with the electronic medical records, which are broader. And so like that connectivity piece and the workflows make it easier to access the information.
Wonderful. The EMR integrations that you talk about at Foundation One, could you comment a little bit more on that, Brian, and like how that helps the physicians and how that may help the patients? And one question that I always come up with is that with the 21 Centuries Care Act, would that information be released to the patients directly, and how overwhelmed can they be if that is the case?
Yeah, it's a great questions. I think, we've talked a lot about how to generate this information and like how to get it back in a way to help make the best decisions. And so, it needs to be available in like the ways that doctors practice, or that patients and doctors see each other. So EMR integrations are like really important for us. And this, I mean, for me, it's like from my clinical experience, I had Epic, and I'm also someone who likes to spend as little time as possible that's not directly interacting with a patient. So if I have to open up a bunch of different like access screens, and already with radiation oncology, I have to have like that record open and Epic open. So like if it's not there, and I get really used to my workflow, so I don't want to learn new things all the time. So if like for me, if information's available and I can just click on that tab and I can track it over time, like that's going to make it easier for me to find the information and have more time with the patient to discuss the information. So that's like really important for us to be able to have that show up. And then you talk about the patient experience. And so, I mean, this is I think we're not unique in this kind of the situation about like, what do patients have access to and how do they interpret the information? And I think in a good way, the trend has been more access to information in the medical record. At the same time, then us in the healthcare space have to make sure that information is either interpreted well or there's an expectation. So like I'm a neuroradiation oncologist, right? So patients will see their MRI all the time before they come and talk to me, and they'll see something was called as like a recurrence
Yeah.
And I said, no, it wasn't. So I ended up changing my workflow to see patients the same day as their MRI, so it's not sitting out there. And then for us, we for foundation medicine, we think about like, what's the evolution of our reporting? Is there like a patient report that's not like here patient, go figure it out, but it's, I know that you're going to have a meeting with your doctor, and like, what's the information that goes back to the doctor, goes back to the patient, so that the time that they spend together, because that's like a sacred interaction of trying to, I saw my role as a physician is translating complex information into a patient's value system and then helping them make the best decision for them. And if we can help that be a partner to both of those parties on the back end of foundation medicine to say, here's the conversation that's worth having. And so that you're not trying to figure that out, or patients don't come in with something they Googled or something, the information where it's like a lot of, we think that could be a real benefit. And so we're working through that. This is another reason why we love partnering with people like you and your organization. So, because you're there, in those interactions, and whatever way we can best support that interaction is what we're looking to do.
Wonderful, wonderful. And I know we've already talked about the cost, and you mentioned 87% patients have $0 financial responsibility, and that's brilliant. Is there any kind of mapping that you guys have as a layout for how the coverage is across the United States? Are there any states that are better than others about providing such coverage, and how is Minnesota doing for such coverage?
Yeah, well, I think the whole span is pretty complicated. I would say that what we had with the FDA approval and the companion diagnostic, we had kind of this dual approval through FDA and through Medicare as a national coverage determination. So, that's the kind of foundation for our coverage, to say anybody with Medicare actually has a national coverage determination that foundation medicine tests, both foundation 1 CDX and foundation 1 liquid CDX, are covered. And then everything else is really not only a state by state, but a payer by payer interaction, so that I think we want to handle that complexity on our end to get to that 87% pay zero out of pocket, because that's the kind of thing we want to continue driving down our costs, especially as like the tests evolve and there's new kind of sequencing technologies come out and we move towards even broader kind of sequencing that we do now. Making sure that like the sequencing costs, the data storage costs, all those kind of things, we can drive those costs down, work with payers, because we think this is just core information about a cancer. And I don't think that, we think that the coverage will continue to improve over time, because there's no world in the future where like genomic information of cancer, which is a genomic disease, isn't the core kind of piece of the diagnostic, predictive, prognostic. It's the information that's going to be available. So we're working really hard on all of that, that work. And we'll get to a place where there'll be coverage. But like to your point about Minnesota, the top 3 Minnesota payers have in-network status for both F1 CDX and F1 liquid CDX, in addition to the national coverage determination at Medicare.
Perfect.
Yeah. So, we're talking about cost, coverage, all these different kind of policy implications of things. I know that you've worked a lot with ASCO and advocacy, and like that could range from anything from advocating for the patient to climate equity, all those types of things. I'd love to hear a little bit more about your experience there and how that kind of integrates with everything that we've talked about so far.
Yeah, so I've been fortunate enough to collaborate with ASCO and work for ASCO on many committees and task forces. And I think the two most close to me personally are the advocacy work that we do for Government Relations Committee, where by means of that, we basically advocate for our cancer patients and cancer-based topics at the Congress, Capitol Hill, both at Washington, D.C. and locally here at the grassroots level. So I think that's really good. In the past, we've worked on topics like prior authorization and telemedicine and things like that. So I think that work is extremely rewarding to me. The patients, at least in my clinic, love to hear this kind of work, so they know that, when we at the clinic are spending so much time at prior authorization processes, the patients love to know that it's being talked about at the leadership level too, and they are not by themselves in this battle. It drives me crazy sometimes in clinics when simple things get denied. But there's a lot of work behind the scenes that goes on, so that's good. And then the other part that's my most recent passion is the climate work that we are doing under the Health Equity and Outcomes Committee. So ASCO created a task force on climate a year ago, and we've been working on creating policy statement under that umbrella. I've learned how much climate is actually intricately involved with the cancer care. We have almost 14% of lung cancer globally that is attributed to air pollution, wow, which is now considered to be a group 1 carcinogen. Similarly, with the thinning of ozone layer, there is more ultraviolet rays exposure on the planet, and that has led to increased incidence of melanoma. So if you compare the rates of melanoma in 1980s to 2022, there has been so much increase in incidence, almost 4-fold increase. And all of that is attributed to either UV rays or the tanning beds. And both of them also enjoy the group 1 carcinogen credit by IARC now. So, those kind of things. And the other very important piece is that, climate change leads to all these weather crises. And when we have a weather crisis, that kind of impacts access to care. And then again, the racial minorities and the minor ethnicities, they're the ones who take the most significant hit. That further leads to disparities. So, we cannot, in the healthcare world and in the cancer world, we cannot deny that these two are intricately linked. And we need to start educating ourselves and make ourselves more aware into how we can reduce the carbon footprint that we all are creating. And who knows, one day we'll come up with a biomarker which will tell us this cancer is related to air pollution, and then we'll connect the dots and bring precision oncology into the picture as well. The other area where I think precision oncology and climate and cancer are all of them are linked is, as we kind of dive more and more towards targeted therapy, we definitely are reducing patients, transports to the clinic. So if they're not getting infusions once every 3 weeks or once every 4 weeks or whatever, then of course, that's lessening the carbon footprint. Where there's also some data, not robust data, but some data in looking into the radiation regimens and if we do more accelerated, consolidated regimens, would that reduce carbon footprint? So I think we're all interconnected, and we just need to keep our minds open and not turn our backs towards this very important topic. So I'm very passionate about it. And by the way, once you have integrated results in the EMR, I think we'll reduce a lot of paper waste.
Oh, that. Absolutely. Yeah, no more faxes.
So yeah, I'm excited for that world.
Yeah, so kind of summarizing all of the stuff we talked about, where do you think this is all heading, the field of precision oncology?
I could not be more excited for precision oncology at this point. I think it's prime time for both, targeted therapies and the tests like Foundation Medicine has, both for solid tumor and liquid biopsy. I think there's still a lot of work that needs to be done, especially I think on the advocacy front, and maybe the national societies will come up with dedicated precision task forces, because I don't think it's a minor topic anymore. I think it's a whole science in itself, which needs a lot of attention at this point. And who knows, at some point you guys will create testing kits that the patients can just poke in their fingertip and have their biomarkers reported at home, like COVID test kits. So who knows? I'm very excited and optimistic about it.
Yeah. Well, thanks so much for this conversation.
Yeah. And how about yourself? Where do you envision this going?
Same. I mean, I think, I talk about this a lot, but I think the best book on kind of the history of cancer is The Emperor of All Maladies. I love that book.
Yes, I do too.
And at the end of it, they talk about, like, imagine 2050 when you can go into like a doctor's office with a thumb drive with all the genomics of your cancer and help make decisions. And, I'm proud to work at this organization over the last 10 years. That's pretty available now, so, and it's in a certain segment of cancer care right now, but like the future is going to be genomic, a genomic foundation, no pun intended, for like all of the decision making that needs to happen. And, it's not, Foundation Medicine's a piece of that puzzle, but like getting to work with kind of you and groups like yours that are setting up precision oncology, not only to get like the best kind of test results back, but to what does that mean for the patient, and ultimately have them have more options, have those options happen quicker through better clinical research, and then, have them make the best decisions that they can. If they had perfect knowledge and understood all the complexities of everything, how would they make the decision? And so that best decisions, best options, and this disease of the genome that we've really 4,000 years of cancer care and really have only started leveraging it in the past 10 years. It's a really exciting time for precision oncology, and I so lucky to be going on this journey with people like you to see what's going to happen in the next 10 to 20 years.
Wonderful. Well, it was great chatting with you, Brian. Thank you so much for your time. I appreciate it. Thank you.
Nice chatting with you as well.